Assalamu alaikum. Hope everyone is doing well. First off, Ramadan Mubarak. Allah يتقبل منا ومنكم الصيام والقيام وصالح الأعمال. My name is Shahd Heijani. I'm a fourth year medical student, and today I'll be giving you the new session on the thalamus, internal capsule, cerebellum, and basal ganglia. Now, this is going to be a recorded session, so we sadly cannot make it. Ask me any question you need at any time. You have my contact information, and I also have a few questions throughout the slides at the end of every section. And yeah, feel free to pause the recording and solve them. Now, starting off with the thalamus, Bismillah. Now, for every section or for every topic, we'll start off with locating the structure and then the anatomy, and then the pathways, nuclei, all those things, and then the pathology. And finally, we have a few questions. Now, starting off with the thalamus, just a bit of embryology in order to locate the structure. We have the prosencephalon, mesencephalon, and the rhombencephalon. Here we only care about the diencephalon, which will give us the thalamus and the hypothalamus. Now, we have associated cavities, and together with those, the cavity of the thalamus will be the third ventricle. So now we can locate the structure. Here we have horizontal section, here we have the coronal section. This structure, the gray structure here, is the thalamus. So the cavity associated with it would be the third ventricle. Here you have the internal capsule, here you have the basal ganglia. We'll talk about all those later on. For now, we care about the thalamus. Now, this is a sagittal view of the brain. Again, here we have the thalamus, but now we have other structures we need to locate other than the thalamus. To locate them, we need to see the hypothalamic sulcus. This is the hypothalamic sulcus. It will split those structures into structures above the sulcus and below the sulcus. Above, we have the thalamus. We also have the metathalamus and the epithalamus. Then the sulcus, and then below the sulcus, we have the subthalamus and the hypothalamus. I think hypothalamus is covered in other lectures, so here we will be focusing on the other structures, mainly the thalamus, and then just one slide on each of the rest of them. Now for the gross anatomy. Here you can see the thalamus again, those bulging structures. The thalamus would have two ends and surfaces, obviously. Now you have an anterior end and a posterior end. The posterior rounded end will be the pulvinar. We'll be talking about all those nuclei and all those structures later on. And you have the anterior end. One more thing I forgot to mention, I have stuff written beneath the slides from your transcription and from other sources. So feel free to check them out, or I'll be focusing on the major high-yield stuff in my explanation. So don't worry, inshallah will be covering everything. Now, this is another view. This is a schematic diagram. Those colorful structures, this is the thalamus, and different colors represent the different nuclei we'll be talking about. Here in the medial side, you can see the cavity of the third ventricle. Here you have the interthalamic connections between the thalami. Here you have the different nuclei. You have the dorsomedial nucleus, you have the lateral nuclei, the anterior nucleus, and from the lateral surface here you have the internal capsule, and you have the external medullary lamina. Now let's talk about the, okay, before the nuclei and the connections, let's talk about the blood supply. For the blood supply, we have three main arteries supplying. We have number one, the posterior cerebral artery. Two is the posterior communicating artery, and three is the artery of Percheron. Those will have significance when we talk about the strokes and the lesions that can happen in the thalamus. But for now, I want you to remember that the blood supply of the thalamus, you have the posterior cerebral artery, the posterior communicating artery, and the artery of Percheron. Now for the connections. We have something called reciprocal connections. So you have connections going to the thalamus and connections going from the thalamus, and they affect each other, and they will affect the brain function and the motion, the senses, and so on. So you have information coming from the brain and the spinal cord to the thalamus, and then this will cause the thalamocortical neurons to send impulses to the fourth layer of the cortex. Now the cortex will have different layers. We have the molecular, external granular, external pyramidal, and so on. We care about the fourth layer, which is the internal granular layer. So the thalamocortical neurons will go to the internal granular layer. We have different neurotransmitters involved with the CNS. You have glutamate and you have GABA, mainly. we have other things, but for now, focus on those two. Glutamate is excitatory, so whenever we say glutamate is released, the structure will be like enhanced or excited. When we have GABA, this will inhibit the structure. So glutamate is excitatory, GABA is inhibitory. Here we have glutamate, so the thalamus will excite the cortex. And then we also have cortex modifying the thalamus output, which is the reciprocal connections. So you have thalamus affecting the cortex and the cortex affecting the thalamus. Now moving on to the nuclei, which is the main thing we need to know about the thalamus. They are divided by this Y-shaped band into anterior group, medial group, and the lateral group. The anterior group will have the anterior nucleus. The medial one, which is the blue one here, will have the dorsomedial nucleus. And the lateral one will have all those. So we will be discussing them in detail later on. But for now, I want you to know that they are divided into two tiers. You have the ventral and the dorsal and so on. Let's take them one by one. Let's start with the anterior nucleus or the anterior group. Anterior group is involved in memory. So any lesion in the anterior group will affect the memory. Okay. Let's talk about the pathway. Now the pathway will start from the hippocampus. Remember that the main structure involved with memory is the hippocampus. So a lesion in the hippocampus will cause anterograde amnesia. You can't form new memories. So now let's talk about anterior group, starting from here. The hippocampus will go, the impulse will go from the hippocampus to the fornix. So here you have the fornix, and then to the mammillary bodies. Mammillary bodies are also important in memory. They're affected in certain conditions such as Wernicke-Korsakoff syndrome, which is affected in alcoholics. So they will have memory loss, confabulations, and all those things. But this is a story for later. And now let's talk about the pathway from the hippocampus to the fornix to the mammillary bodies, and then to the anterior group or the anterior nucleus of the thalamus. And finally, it will go to the cingulate gyrus of the frontal lobe. Hippocampus, fornix, mammillary bodies, anterior nucleus, cingulate gyrus. And this is part of the Papez circuit of the limbic system. So whenever they ask you about this circuit, you need to know this pathway. So this circuit is involved with the anterior group and the memory. Okay. Now for the medial group, we said this is the medial group. We have the dorsomedial nucleus. Now, what is the pathway? So it will start from the amygdala, from the prefrontal cortex, and the temporal lobe. What are those structures involved in? They're involved in regulating the mood, emotions, memory, and arousal. So a lesion in the medial group will affect those functions: mood, emotions, memory, and arousal. Starting from the amygdala, prefrontal cortex, and the temporal lobe, it will go to the dorsomedial nucleus, and then to the prefrontal cortex and the cingulate gyrus. So we said anterior for memory, medial group for mood, emotions, memory, and arousal. And then we have the lateral group. We said the lateral group is this yellow thing, and it's divided into tiers. So you have the ventral tier and the dorsal tier. Dorsal tier is those structures. You have the lateral dorsal, lateral posterior, and the pulvinar. Lateral dorsal, lateral posterior, and pulvinar. Remember when we said the pulvinar forms the posterior end of the thalamus? So this is the pulvinar. And then you have the ventral tier. Ventral tier has the ventral anterior, ventral lateral, ventral posterior, which is divided into ventral posterior lateral, ventral posterior medial. So we have the ventral tier and the dorsal tier. Let's take them one by one, starting with the lateral group ventral tier. Here we have the VAVL complex, the ventral anterior ventral lateral complex. Remember that the ventral anterior ventral lateral complex is for motor function, so it's for movement. Meanwhile, the ventral posterior lateral ventral posterior medial is for sensory. Ventral anterior ventral lateral is for motor, but each of them will have like impulses or inputs from different structures. So we have the ventral anterior nucleus, which takes the motor information from the basal ganglia. The lateral nucleus will take from the cerebellum. Basal ganglia will be discussed, both of them, basal ganglia and cerebellum, will be discussed in the next sections of this PowerPoint. But I want you to remember that basal ganglia will help with initiating the movement. Cerebellum will help with coordinating and fixing, fine-tuning the movement. So lesions in those areas will have different effects. So let's start with the ventral anterior nucleus. So the connections will start from globus pallidus. Globus pallidus is located in the basal ganglia. Again, we'll talk about the basal ganglia in detail later on. For now, just remember that the information will come from from the globus pallidus to the ventral anterior, ventral lateral nucleus, and to the motor cortex. So whenever we talk about a basal ganglia, we will mention those nuclei again. So this will be involved with initiating movements. And whenever we have the tracts going from the brain to initiate movement, they will decussate. So we'll have contralateral side. So lesions in the basal ganglia or those nuclei will cause problems in the contralateral side of the body. Okay, so we have lesion in the left, the movement on the right will be affected. In the ventrolateral nucleus, we said we'll get the motor from the cerebellum. Cerebellum is involved with coordinating or fine-tuning the movements. The connections will be from the dentate nucleus of the cerebellum. However, here, keep in mind that it will cross the midline to the ventrolateral nucleus, and then we'll go to the motor cortex. So if we have something that's going from the cerebellum, it will cross the midline to the cortex, and then from the cortex, again, the motor nerves will cross the midline again to go and affect the movement of the body. So this double crossing will, what does this double crossing mean? This will mean that any lesion will affect the ipsilateral side. So a lesion in the left cerebellum will affect movement in the left side of the body. However, the basal ganglia was the contralateral side. So keep that in mind. Now to the ventrobasal complex, we have the ventral posterior lateral nucleus and the ventral posterior medial nucleus. We said those structures are involved with senses, not movement. Ventral posterior lateral is senses from the body. Ventral posterior medial is senses from the face and the taste. So let's start with ventral posterior lateral nucleus, which will take the senses from the contralateral side of the body. So the connections will be from the dorsal column and from the spinothalamic tract. They will cross the midline to the ventral posterior lateral nucleus and to the somatosensory cortex. So we know senses, they decussate. So lesion in the right will affect senses in the left. Lesions in the left affect the senses on the right. This is for all the senses from the body. Ventral posterior lateral. Ventral posterior medial is the contralateral side of the face and the taste. So the connections will be from the trigeminothalamic tract and the taste. Again, they will cross the midline, ventral posterior medial nucleus, and then to the somatosensory cortex. So the senses are contralateral. Movement from basal ganglia is contralateral too. Cerebellum is ipsilateral. Keep in mind, cerebellum is ipsilateral. Everything else is contralateral. Now, for the lateral group, dorsal tier. We finished the ventral tier. Now, the dorsal tier. Dorsal tier, we said we have the lateral dorsal nucleus, lateral posterior nucleus, and the pulvinar. Now, the nuclei that we discussed before this are the most important ones, so you're more likely to get questions on those rather than those parts. But in order to understand those parts, I want you to remember this brain and what each of them will represent. So lateral dorsal nucleus will take the information from the other thalamic nuclei and it will go to the frontal association cortex, which is the prefrontal cortex. So to affect this area is involved with cognition and decision making. تمام؟ تمام. Now we have the lateral posterior nucleus. The lateral posterior nucleus will go and affect the parietal association cortex, which is for planned movements, spatial reasoning, and attention. And finally, we have the pulvinar, which is connected with the parieto-occipito-temporal association cortex, which is basically for language recognition and so on. Again, just know what those will project to, what they will affect. But I believe you're more likely to get questions on those because they're very high yield. Okay, this is a screenshot from Boards and Beyond. As we said, ventral posterior lateral is for all sensation, pain, temperature, touch, proprioception, and vibration. Ventral posterior medial is from the sensory of the face and the taste. One more thing I forgot to mention is that all senses will go to the thalamus, and they will pass through the thalamus except olfaction. Everything else will pass through the thalamus. Only olfaction will not. Now we also have the lateral geniculate nucleus, medial geniculate nucleus, which will be discussed later, and we have the ventral lateral loop, which will affect the motor function. Now we also have one more thing, which is the reticular nucleus. Now this round structure is the thalamus, as we know, but we also have one nucleus which is curved like this. This is the reticular nucleus, which is the gatekeeper of the thalamus. We need something to keep the thalamus in check. It will control it. So it will help with the sleep-wake cycle and with switching the mode of the thalamus. We'll talk about this in the next slide. But remember what we said about the neurotransmitters? We said we have glutamate and we have GABA. Glutamate excitatory, GABA inhibitory. Reticular nucleus has GABAergic neurons, so it's inhibitory. So when we get like impulses from the brainstem, the cortex, and the thalamus to the reticular formation will release GABA and inhibit output to the thalamus. تمام? This will help us with switching the mode of the thalamus. So what modes do we have? We have the tonic mode and we have the burst mode. Tonic mode is the normal response. Burst mode is during sleep, for example. Tonic mode, here we have something called the rostral reticular formation in the midbrain. This will keep us awake by sending cholinergic impulses, cholinergic output, and that will activate the thalamocortical neurons and will switch off the reticular nucleus. So now the thalamus can function normally. It will send the neurons to the cortex and function normally. In burst mode, which is also the oscillatory mode or a hyperpolarized state, we have an intrinsic rhythm in something called the T-type or transitory calcium channels. What does this mean? What will happen? Now, when you have this intrinsic rhythm, this will cause the reticular nucleus to release GABA to the thalamus. You said GABA is inhibitory, so it will inhibit the function of the thalamus by rhythmic bursts of action potential. Those rhythmic bursts will inhibit the thalamus and will keep it in check. So those are the two modes we have. Now, moving on to pathologies, certain strokes that can happen. Let's quickly revise the arteries. We said we have the posterior cerebral artery, posterior communicating artery, and the artery of Percheron supplying the thalamus here. Now, here we have the paramedial thalamic infarction. Paramedial. So it will be near the medial side, and the artery affected here is the artery of Percheron, which is the medial branch of the posterior cerebral artery. So it will affect the medial part of the thalamus. So we have medial thalamic infarction. So what will happen? What functions will be affected in the body and in the patient? It will affect the alertness, awake, like arousal, and the memory too. So the patient will be comatose or agitated, and they may or may not have hemiplegia or hemisensory loss according to the structures that are affected. But mainly, patient will be agitated, comatose. Sometimes the oculomotor nerve is involved, so this will affect the eyesight too. Patients may take days to weeks to recover. Alertness can return. However, the patient will not fully recover because of severe memory dysfunction. So paramedial thalamic infarction. We have what artery is affected? Artery of Percheron. Patient will be comatose, agitated. Alertness can return, but severe memory dysfunction will cause poor prognosis in the patient. Thalamic pain syndrome is very important. Very important. We have lacunar stroke involving the thalamoperforating branches of the PCA. So the thalamoperforating branches will have a stroke, and this will affect the ventral posterolateral, ventral posteromedial nuclei. Ventral posterolateral is for the sensation from the body. Ventral posteromedial is for the sensation from the face. And we said it's contralateral. So if you have contralateral side of the body affected, contralateral side of the face affected, and it's only sensory. So in this condition, we have all somatic sensation in the body and face. Contralateral to the affected thalamus will be affected. So it's pure hemisensory loss. We lost sensation in the body because of the ventral posterolateral stroke, we lost sensation in the face because of the ventral posterior medial stroke, and they're both contralateral. So you have a pure hemisensory stroke. You will have central pain, so the patient will have excruciating burning pain in half of the body provoked by light cutaneous stimulation. So light touch will cause severe pain in the patient. Won't respond to any anti-inflammatory or analgesics. Now we covered the thalamus. Very quick review. Now we said we have reciprocal connections. We have nuclei separated by the Y-shaped band, anterior, medial, and lateral group. Anterior for memory, going from the hippocampus, fornix, mammillary bodies, anterior nucleus to the cingulate gyrus, part of the Papill's circuit. Medial group for mood, emotions, memory, and arousal, from the amygdala, prefrontal cortex to the cingulate gyrus. Lateral group, we have ventral tear with dorsal tear. In the ventral tear, we have ventral anterior nucleus, ventral lateral nucleus. Both are involved in motor function. Ventral anterior from the basal ganglia, ventral lateral from the cerebellum. Cerebellum lesions ipsilateral, everything else contralateral. Ventral posterolateral or VPL is for contralateral sensation from the body. VPM, contralateral sensation of the face. And then we have those three nuclei. And we said reticular nucleus is the gatekeeper. It will release inhibitory impulses, which is GABAergic to the thalamus. We have two modes, and we discussed the infarctions, paramedian thalamic infarction and the thalamic pain syndrome. This is for the thalamus. Now we said we have above the sulcus, we have the thalamus, metathalamus, and then we have other structures. Metathalamus, we need to know two things: lateral geniculate body and the medial geniculate body. Lateral geniculate body is for is the visual relay nucleus. So I want you to remember L for light. So L, light, vision. Medial, M, music, auditory. So medial geniculate body is for auditory relay. So any lesion in the lateral geniculate body, which is the one here, would result in contralateral homonymous hemianopia without macular sparing. So the half of the vision or the visual field will be affected. So they won't see half the visual field, and there's no macular sparing. So the full half will be affected. Medial geniculate body will affect hearing. So lesion would result in bilateral partial hearing loss. The doctor included the whole pathway for each of them. They never ask about that. However, I included it in the notes section. You can go through it and read it if you want. But the most important thing is knowing the location and what will be affected if they're diseased. We also have the epithalamus above the sulcus. Epithalamus will have the pineal body and the habenular nuclei. Pineal body is important for circadian rhythm regulation. So it will help with the sleep-wake cycle because the pineal body will secrete melatonin at night. Melatonin is a serotonin-derived hormone, so this is important for circadian rhythm regulation. Sometimes you can have tumors in the pineal body. So a pineal tumor can compress the midbrain superior colliculi. Let's look at the location. So here we have the thalamus, and here is the epithalamus. This is the pineal body. So you can imagine if there's a tumor that's expanding and then compressing the structures around it, it will compress. It will compress the midbrain here, and it will also compress the cerebral aqueduct. So here, this is the aqueduct just behind the midbrain, and this is the midbrain. Now, when it compresses the midbrain, superior colliculi, and the pretectal area, it will produce something called Perinaud syndrome. In Perinaud syndrome, the patient will have vertical gaze palsy, so they can't look up. So they'll have sunset eyes, they'll look down, they'll have lid retraction, and sometimes nystagmus too. And when it compresses the cerebral aqueduct, this will result in non-communicating hydrocephalus. So as you can see here, there is the bulging fontanelle, which is a sign of hydrocephalus. Non-communicating because it's in the cerebral aqueduct, so the CSF cannot pass through the cerebral aqueduct to the fourth ventricle. So this is due to pineal tumors. Now to the subthalamus. Subthalamus is below the sulcus. The other structures were above the sulcus. This is the subthalamus, and just beneath it is the substantia nigra. Subthalamus is very important in basal ganglia, so we will talk about it in depth in the basal ganglia pathways. All I want you to know for now is that lesion in the subthalamus will cause hemiballismus. Hemiballismus is contralateral involuntary flinging movement of one or both extremities. So as you can see, the patient will have sudden flinging movement of the contralateral side of the body. And the blood supply of the thalamus is the thalamoperforating arteries, which are branches from the posterior cerebral artery. For now, this is enough for the subthalamus. We'll talk about it in more detail in the basal ganglia. Now, we're done with the first section, thalamus. We have 3 questions about the thalamus. Again, you can pause, answer, but I'll explain explain the answers. Starting with the first question. If the globus pallidus internus was degenerate, which of the following thalamic nuclei will get transmural atrophy? GBI is globus pallidus internus, which is part of the basal ganglia. So we said basal ganglia is involved with motor function. Motor function is related in which nuclei? Ventral anterior and ventral lateral. So the correct answer here will be ventral anterior. Anterior is for memory, ventral posterior medial, and posterior lateral is for sensation. And dorsomedial nucleus is for the other stuff we discussed, the arousal, emotions, memory, and so on. Second question, correct sequence of Capet circuit. Capet circuit is involved in the pathway of memory. It's part of the limbic system. Here, in this context, we care about memory, which is in the anterior nucleus pathway. So the correct pathway out of those options is fornix, to the mammillary bodies, to the anterior nucleus, parahippocampal gyrus, to the cingulate gyrus. So it will start in the hippocampus to the fornix, and it will end in the cingulate gyrus of the frontal lobe. تمام؟ تمام. Last question for this section. 56-year-old patient presents to the ER with complete loss of sensation on the right side of body. A few days later, the patient presents with freezing pain on the same side. Which of the following structures could be damaged? Full, pure hemisensory stroke. Pure hemisensory. So half the body, its only sensation means thalamus. You said thalamus is contralateral. The only thing that's ipsilateral about anything is cerebellum. Everything else is contralateral. So here we have freezing sensation on the right side. We have loss of sensation, then freezing pain on the right side. So what will be affected is the left thalamus. Now, second part will be about the internal capsule. Internal capsule is a short part, so hopefully we won't spend that much time in it. Again, we start with the anatomy first. So for the anatomy, we have 3 limbs of the internal capsule. First, let's locate it. This thing in green is the internal capsule. We said here we have the thalamus, and here we have the structures of the basal ganglia. Structures of the basal ganglia, which are the putamen, lobus pallidus. We'll discuss all those later. And this structure is the internal capsule. Internal capsule will have anterior limb, posterior limb, and the genu, which is the curve. Now, let's discuss what happens in each of those. Remember the fibers related to each one of those limbs. This is very important. Anterior limb will have the thalamocortical fibers from the dorsomedial anterior nuclei of the thalamic nuclei, and will project to the frontal lobe. So anterior limb, thalamocortical fibers, keep that in mind. Genu is involved with corticobulbar tract. Corticobulbar. So this is involved with the motor nuclei of the cranial nerves. So it will affect the head. It will affect the motor nuclei of the cranial nerves. Stroke in the genu, corticobulbar palsy. We'll discuss this in the pathology section of this part. Posterior limb, mainly corticospinal tracts. And the corticospinal tract is arranged in a way that closest to the genu is the fibers related to the neck, and the posterior side is for the lower limbs. So here, closer to this side are the neck fibers, and closer to this side are the lower limb fibers. You also have thalamocortical fibers from the ventral posterior nucleus. So anterior limb, thalamocortical, genu has corticobulbar, posterior limb has mainly corticospinal, also thalamocortical. تمام. We also have those structures which are the medial geniculate nucleus, lateral geniculate nucleus we discussed in the thalamus section. So we have some formations we'll be discussing here. So you have the sublentiform and the retrolentiform. Sublentiform is involved with auditory impulses. So auditory, we said medial geniculate body, medial music, so hearing. So medial geniculate body will send fibers to the temporal auditory cortex through the sublentiform pathway. Retrolentiform is for the optic. So optic, we said L light, lateral geniculate body. So from the lateral geniculate body to the optic radiation. So here you have the from the lateral geniculate, you have the optic radiation. From the medial geniculate, you have the auditory radiation. Now, for the blood supply of the internal capsule, we have anterior choroidal artery and the lenticular striate branches of the MCA, medial cerebral artery. This is the MCA. And we'll have the anterior choroidal artery, which is more towards the genu of the posterior of the internal capsule. And we have the lenticular striate branches, which are those mainly for the posterior limb. So now that we know the blood supply of the internal capsule, we can talk about the strokes. We said we have the anterior choroidal artery and the lenticular striate branches of the MCA. Strokes. We have strokes in the genu, strokes in the posterior limb. A lacunar stroke in the genu, which is here, marked here, which is at the curve in the internal capsule, it will cause corticobulbar palsy. We said corticobulbar is the pathway involved in the genu. Corticobulbar is for the head, for the cranial nerves. Corticobulbar pathway is upper motor neuron. So upper motor neuron lesions differ from the lower motor neuron lesions. So what happens here is, due to the stroke in the genu, in the anterior choroidal arteries, you have contralateral lower face weakness because of the corticobulbar tract to the facial nerve. You have lower face weakness, sparing the forehead because, here the upper motor neurons, if it's affected, it will spare the forehead. It will just affect the lower side of the body, lower side of the face, sorry. However, if you have a lower motor neuron lesion, this will affect the full face. So here we have upper motor neuron, so it's contralateral lower face weakness. And you also have transient deviation of the uvula. So uvula will move towards the lesion. So if it's a stroke in the right internal capsule in the genu, so the uvula will move towards the right. There will be weakness in the lower face on the left. And you have deviation of the tongue away from the lesion on protrusion because of the corticobulbar tract to the hypoglossal nerve. Now, meanwhile, in Bell's palsy is due to facial nerve damage. Facial nerve damage is lower motor neuron. So this will have different different signs. For example, there will be full face is affected. The tongue will deviate towards the lesion, and you have other stuff. For now, we are focusing on the corticobulbar palsy due to a stroke in the genu, which is upper motor neuron. So you'll have different presentation in the patient. Moving on to the posterior limb stroke. So a lacunar stroke in the posterior limb will affect, we said mainly we have the corticospinal tracts. We also have thalamocortical. So affecting corticospinal tracts means we will have contralateral hemiplegia. So contralateral side of the body movement will be affected. Contralateral anesthesia too because of the thalamocortical tract. And contralateral homonymous hemianopsia because of the optic radiations. Optic radiations will also be affected, and we have homonymous hemianopsia where half of the visual field will be affected. And you also have a slight bilateral hearing loss, which is due to the auditory pathway. So we said here we have the auditory pathway and the optic pathway; those can be affected too in the stroke in this lacunar stroke. Mainly corticospinal, also thalamocortical, and genu, we said it will affect the cranial nerves, it will affect the head. Now, this is all for internal capsule. It's kind of straightforward. Just keep in mind the arrangement of the anterior, the genu, and the posterior. Closer to the genu will have fibers to the neck. Closer to the posterior side, fibers to the lower body, and then the different strokes and the blood supply. Questions? If the posterior limb is damaged, which artery is affected? Now we mentioned the thalamo-perforating and the artery of Percheron in the thalamus. So the artery affected here in this case is the lenticular striate branch of the right MCA. Right, left, it depends on the scenario. Lenticular striate branches of the MCA will affect the internal capsule. Also, we mentioned the anterior choroidal arteries, which will mainly affect the genu. Next question. 56-year-old patient presents to the ER with complete loss of motor function on the right side of the body. He suffered from a stroke. Which of the following sites could be damaged? Pure hemisensory stroke is thalamus. Pure motor stroke is internal capsule. Keep that in mind. If the patient has full loss of sensation or full sensation of pain, thalamus, full loss of motor function, internal capsule. Contralateral. So we have the right side of the body, so the left will be affected. And we said this is pure motor, so this will be internal capsule. So the correct answer is left internal capsule. This was it for the first section, which is the thalamus and the internal capsule. We can move on to the cerebellum. As I mentioned, and since this is not live session, I can't take questions live. So you have my contact information. If you have any questions, please feel free to email me or text me. تمام. Now to the cerebellum. Okay. Just 1 second, and we'll be back. Now let's proceed with the cerebellum. Again, starting with locating it and its anatomy. Now, this is the cerebellum. It is located behind the pons and the medulla. So here you have the midbrain, the pons, and the medulla. So cerebellum is located behind those. It forms the roof of the fourth ventricle. Let me turn on the laser pointer. Oops. No. Okay. So we said this is the location of the cerebellum forming the roof of the fourth ventricle. And we have two fissures. We have the primary fissure, which will like split it into the anterior and the posterior lobe. And we have the horizontal fissure, which will split it into superior and inferior ends. Now, this is for the location of the cerebellum. Now, for the gross appearance, as you can see, it has like those wave-like structures or folds, which are the folia. And it's from the outside, it's gray matter, and then you have the white matter inside, and then you have extra gray matter inside, which are the nuclei. Now, to remember all the structures or everything related to the cerebellum, you need to know the rule of three. So you have three of everything. You have three lobes, three peduncles, three nuclei, three functional areas, three histologic layers, blood vessels, and so on. So let's take them one by one, starting with the lobes. So we have three lobes. We have the anterior lobe, we have the posterior lobe, and the flocculonodular lobe. So here the green is the anterior lobe, red is the posterior, and this thing is the flocculonodular lobe. Now, lesions in every one of those lobes will have different effect on the body. So, for example, the flocculonodular lobe is involved with balance and eye movements. So, if you affect the flocculonodular lobe, the patient will have nystagmus and loss of balance and so on. We will talk about those like conditions in detail after we finish all the structures in the cerebellum, because everything will fit into place because all the lobes, the peduncles, the fibers, everything is interconnected. So let's cover everything, and then we'll talk about the lesions. But only thing I need you to remember for now is that lesions in the middle of the cerebellum, so in the vermis and everything in the middle, will affect more of the gait and the trunk. So the trunk will not be stable, the trunk of the patient will not be stable. If it's affecting the periphery of the cerebellum, so this will cause lesions that, for example, it will cause something called the cerebellar signs. For example, dystiadokinesia. So if you ask the patient to do this, they won't be able to do it, so they will start mixing up and they can't do it. They can do the finger to nose test and such signs, and they will start like walking towards the lesion. Remember, we said cerebellar lesions are ipsilateral. Everything will be ipsilateral. We'll talk about all this later on. Let's continue with our rule of threes. We said three lobes: anterior, posterior, and flocculonodular. We have three peduncles. So peduncles are those structures. So for example, here we have the superior peduncle, which is near the midbrain, middle peduncle near the pons, and the inferior cerebellar peduncle near the medulla. So those are the peduncles. Biggest one will be the middle peduncle. And what we need to know about this is that superior peduncle is output from the cerebellum, middle and inferior is input to the cerebellum. So fibers and input that are going to the cerebellum will go through the middle and inferior peduncle, and fibers going output from the cerebellum, so out from the cerebellum through the superior peduncle. For the nuclei, we said you have gray matter and then white matter, and then we have nuclei inside. We have three important nuclei, deep nuclei. We have the dentate, which is the most lateral one, near the hemispheres, near the cerebellar hemispheres. And then you have the middle, you have the interposed nuclei, which are the emboliform and globose nuclei. And then the most medial one, which is near the vermis of the cerebellum, vermis is the structure in the middle, is the fastigial nucleus. So you have the dentate nucleus, the most lateral, and then emboliform and globose, which form the interposed nuclei, and then you have the fastigial nucleus. Again, those will be affected in different strokes and different lesions, and each one of them will correlate to a functional area in the cerebellum. What are the functional areas? So we discussed the lobes. We said we have anterior, posterior, and flocculonodular lobe. We discussed the nuclei. Now let's discuss the functional areas. So each functional area is responsible for a different thing. Starting off with the cerebrocerebellum. Cerebrocerebellum is the most lateral one. Cerebrocerebellum, what nuclei is most related to this one? The dentate nucleus. Remember, we said the dentate is the most lateral one. So it makes sense that the nucleus related to the cerebrocerebellum is the dentate nucleus. This is involved with fine motion, so for motor function. And we said lesions towards the hemispheres will affect like the extremities more. So, for example, it will cause leg ataxia, movement in the extremities, and so on. We have spinocerebellum in the middle. This is spinocerebellum. So spinocerebellum is involved with posture. So we said lesions in the middle of the cerebellum will affect gait or the truncal ataxia. So truncal ataxia means the trunk will not be stable. The patient won't be stable. There is a difference between sensory ataxia and cerebellar ataxia. So sensory ataxia is when senses are affected. So for example, in Romberg test, when the patient will close their eyes and then they'll be unstable because they can't see, that is sensory ataxia. That's not related to cerebellum. Cerebellum is more involved with fine-tuning the motion, with planning the motion, with learning about the motion. So the patient will not be stable in all cases. So it's either truncal ataxia if it's affecting the middle of the cerebellum, or leg ataxia and other cerebellar findings if it's affecting the periphery or the hemispheres. So we said we have three functional areas: cerebrocerebellum, spinocerebellum, and the nuclei affected mainly are the interposed nuclei. You also have the fastigial, but mainly the interposed. And you have the vestibulocerebellum. Vestibulocerebellum is this. And remember, what lobe is this? We said this is the flocculonodular lobe. So vestibulocerebellum is related to the flocculonodular lobe. We said flocculonodular lobe is for balance and eye, so this makes sense. Vestibulocerebellum is involved with balance and eye. And main nucleus is the nucleus fastigial. We have three functional areas: cerebrocerebellum, motion; spinocerebellum, posture, and the anterior of the spinocerebellum is related to the lower limbs. So this is a diagram from your slides. So the anterior of the spinocerebellum is related to the lower limbs, and then when you go back, it's more related to the upper limbs, the head, and so on. So those are the three functional areas, and we related them to the nuclei in the cerebellum. And this is another diagram. Again, dentate nucleus, emboliform globus forming the interpost, and fastigium nucleus, which is the most medial one. Three histologic layers. So you have three layers. The uppermost one is the molecular layer, middle one is the Purkinje layer, and finally you have the granule cell layer. This will be more important when we discuss the fibers. For now, we're just discussing the anatomy and the rule of threes. So just remember that we have three histologic layers, a molecular, Purkinje, and then granular layer. So now for the blood vessels. Again, we have three blood vessels. We have the superior cerebellar artery. This is the basilar artery, as you know. Here we have the pons and the medulla, just a bit of orientation. So this is a side view. Now, when we're looking at the side, we have the superior cerebellar artery. You have the ICA and the PICA. ICA is the anterior inferior cerebellar artery. PICA is the posterior inferior cerebellar artery. So the three arteries supplying cerebellum are the SCA, ICA, and PICA. Superior cerebellar, anterior inferior cerebellar, posterior inferior cerebellum. Now we discussed the three rule of threes and the anatomy. Now to the function. We said cerebellum will regulate the movement and the posture by adjusting the output of the motor systems. So it will regulate the motor function in the body, and it acts as a comparator, and also it helps with learning the function. So first time you find some like some movements or some actions hard, and then cerebellum will help you with learning the movement, so it will be smoother later on. So it will help with regulating the movement, making it smoother, and it acts as a comparator. So it will compare the intended movement with the actual movement, and it will correct errors. So if this is affected, we'll have something called dysmetria. So for example, if you try to reach out for a cup and you overshoot or you undershoot, so this means the cerebellum is affected, so you can't estimate the distance correctly. So cerebellum will help with regulating the movement and acts as a comparator, which will compare the intended movement with the actual movement. And it will correct for errors in real time. Now, this is another screenshot from Boats and Beyond. To remember, the input to the cerebellum, we said which peduncles, middle and inferior, are the input to the cerebellum. We also have certain fibers, which are the climbing fibers and the mossy fibers. We discussed those in a bit. They also input to the cerebellum. And then within the cerebellum, we have Purkinje cells and the deep nuclei. Deep nuclei we discussed, which are the fastigious nucleus, interposed, and the dentate. And we also have Purkinje cells. We mentioned those when we discussed the histologic layers of the cerebellum. So we also have something called Purkinje cells, which will affect the function of the deep nuclei. Purkinje cells are inhibitory. And what neurotransmitter did we say is inhibitory? GABA. So Purkinje cells will release GABA and affect the deep nuclei. So this is all within the cerebellum itself. Now the output will be from the deep nuclei, mainly the dentate nucleus, but we have like output from the deep nuclei through the superior cerebellar peduncle. This is the general overview of the cerebellum. One by one, starting with the input. You have input from different structures, from the cortex, spinal cord, vestibular organs, and inferior auditory nucleus. This is just a schematic diagram. I know it's not very clear, but just to imagine everything that's happening. Here you have from the inferior auditory nucleus and the vestibular organs going to the cerebellum. We also have from the spinal cord and from the cortex. So from the spinal cord, specifically the posterior and anterior spinocerebellar. So it will take all the proprioceptive impulses from the spinal cord and bring it to the cerebellum. And we also have fibers coming from the cortex to the cerebellum. We said cerebellum will help with fixing the motor function. So it will compare the antecedent movement with the actual movement. It will help with the motor, fine-tuning the motor function. So we need impulses from the cortex in order to adjust our movement in the cerebellum. So starting with, okay, so here we have the cortex. Which fibers we have? The corticopontine fibers, corticopontine. So it will go from the cortex to the pontine nuclei, and then it will cross the midline to the opposite cerebellar hemispheres. So if we have impulses or fibers from the right cortex, it will cross the midline and go to the left cerebellum. تمام? Keep in mind, we're crossing the midline. So it will go to the opposite cerebellar hemispheres. Cerebellum will do its thing, and then it will cross again. So the fibers, the lesions in the left cerebellum will affect the motor function in the left side of the body. تمام? So you have, sorry, bismillah, so many crossings, so many decussations. You have fibers going from the cortex to the cerebellum. So it will go from the corticopontine fibers will go from the cortex to the pontine nuclei. It will cross to the opposite cerebellar hemispheres, and it will affect the motor function. You also have input from the spinal cord, from the vestibular organs, and the inferior auditory nucleus. This is a different diagram that will help you visualize just the input. So I talked about the input and the output at the same time. So I mentioned decussation twice, but in order to not get confused, let's just focus on the input now. Input from the cortex, from the to the pons, decussate to the opposite cerebellar cortex. And then you also have from the inferior olivatory nucleus, spinal cord, vestibular nucleus to the cortex. تمام? For now, the impulses are in this side of the cortex. This is the input. Now we can talk about the output. Output, again, through the cerebellar cortex, we said inside the cerebellum itself, we'll have Purkinje cells, which will affect the function of the nuclei. We said they're inhibitory, so they will release GABA. They will send Purkinje fibers to the deep cerebellar nuclei to affect their function. And then the deep cerebellar nuclei can send their fibers as output from the cerebellum. We said the main output of the cerebellum is through the superior cerebellar peduncle. In middle and inferior were input, superior is output. So we'll get output from the deep cerebellar nuclei to the superior cerebellar peduncle. It will go out, and now it will decussate at the lower midbrain to the ventral lateral nucleus of the thalamus. Remember? We said the nucleus, the thalamus, will have ventral anterior and ventral lateral. Ventral anterior related to the basal ganglia, ventral lateral related to the cerebellum. So this is where it comes in. So we have fibers going from deep cerebellar nuclei through the superior peduncle, decussate at the lower midbrain to go to the opposite ventral lateral nucleus of the thalamus, and then to the cortex to correct the movement. So in input, we had decussation. In output, we had decussation. So lesions in the cerebellum will affect the ipsilateral side of the body. It won't affect the contralateral side, as opposed to the thalamus, internal capsule, cortex, everything else is contralateral. So quickly, input from all those nuclei and from the cortex to the pons. Then it will decussate through the middle cerebellar peduncle. Remember, we said we have superior, middle at the level of the pons, and then inferior. So it will decussate, go to the cerebellar cortex. Output, we have from the deep cerebellar nuclei, decussate at the superior cerebellar peduncle, because it is output, so it's superior. Decussate, go to the ventral lateral complex of the thalamus, and then it will go to the primary motor and the premotor cortex of the frontal lobe of the brain to correct our movement. Cerebellar hemispheres represent the same side, so it will cause ipsilateral lesions. I hope that's clear. Now, moving on to the fibers. We mentioned two fibers in the input. We mentioned the mossy fibers, we mentioned the climbing fibers, and we talked about the Purkinje cells. Let's put everything into place. We said the cerebellar cortex has three histologic layers, remember? The molecular layer, Purkinje cell layer, and the granular layer. Now let's focus on the mossy fibers and the climbing fibers. تمام. Those are the main input fibers into the cerebellum. Mossy fibers are also called the corticopontocerebellar fibers, and they will synapse with the granule cells, and they will cause granule cell excitation. So excitation is glutamate, inhibition is GABA. So those are excitatory, so they will release glutamate. They will synapse with the granule cells. Now, look, this is the mossy fiber. It will synapse with the granule cells in this layer. What will it do? It will activate, to release glutamate, and then it will activate multiple Purkinje cells. And then Purkinje cells will send inhibitory signals to the deep cerebellar nuclei. So here you have the mossy fibers, synapse with the granule cells. Those granule cells will activate the Purkinje cells, which will inhibit the deep nuclei, and this will affect the function of the cerebellum. Those are the mossy fibers. Mossy fibers synapse with granule cells. تمام؟ تمام. Now for the climbing fibers. Climbing fibers come from the inferior olivary nucleus. This is the climbing fiber. It's coming from the inferior olivary nucleus and will go all the way up to the Purkinje cells. It won't synapse with the granule cells. Go all the way up to the Purkinje cells, activate it, and then Purkinje cells will send inhibitory signals to the deep cerebellar nucleus. Mossy will go to the granule, activate it, so the granule will go to the Purkinje. Climbing fibers from the inferior olivary nucleus straight away to the Purkinje cell. تمام؟ mossy fibers will release simple spikes, climbing fibers will release complex spikes, and those two, a balance between those two will help with the antagonist and the agonist muscles motion in order to fine tune the motion, and you can like properly execute the function or properly execute the motion without any errors. Now again, this is those are the fibers if you need a different view, which is from your slides. Here we have the mossy fibers to the granule cells, granule cells to the Purkinje cell, and then this will inhibit the deep cerebellar nucleus. And you also have the climbing fibers, which will go and straight away go to the Purkinje cells to the deep cerebellar nucleus. You also have other cells like basket cells, stellate cells, which will affect the Purkinje cell function. Not very important, just know them. Again, this is another schematic diagram from Dr. Yaqeen. All you need to know about this is look at the decussations, double decussation. So the same cerebellum will affect the same side of the body. Here you have the afferents in blue. So the afferents will go from the cerebellum to go to the cortex, and then the efferents, which are the red, will go and decussate again to the other side. So if we started from the right cerebellum, go to the left cortex, then we'll go to the right side of the body. So region in the right cerebellum, right side of the body is affected. Clear? Inshallah. This is another table from the doctor's slides. I just added it for completion. You can just read it. And those are the muscle patterns. Remember what we said about dysmetria? So normally they will be synchronized. The agonist and the antagonist muscles will be synchronized. The signals will be synchronized so that you can execute the motor function properly. Sometimes you have dysmetria, so you cannot perform accurate and smooth movements. So you have either hypermetria or hypometria. In hypermetria, the muscle will overshoot when you direct it as the target. So, for example, I want to take this cup or whatever. I will overshoot because there is loss of synchronization between the agonist and the antagonists. Again, same thing with the hypometria. So undershoot, so you don't actually reach the target. So yeah, those are the muscle patterns. Now to the pathologies. We discussed the nuclei, we discussed the different layers, the different lobes. Let's quickly revise the lobes to understand what's happening in the pathology. تمام. We said we have the anterior lobe, posterior lobe, and the floccular nodular lobe. Those are, yes, we have the primary fissure, which is separating the anterior lobe from the posterior lobe. This is from the gross appearance of the cerebellum. Now, for the actual functional areas, we said we have cerebrocerebellum, which is for the fine motion, the spinocerebellum, which is for the posture, and the vestibulocerebellum, which is for the balance and the eye movements. And for the blood vessels, we keep in mind that we have the SCA, pica, and ICA, superior cerebellar, anterior inferior cerebellar, posterior inferior cerebellar. طيب وين؟ Okay. Anterior vermis syndrome. We said the vermis is the middle part of the cerebellum. Remember, we said the vermis, or if there are any lesions in the middle of the cerebellum, this will affect the trunk, it will affect the legs, it will affect the gait. Here we have the anterior vermis affected. So the anterior portion of the cerebellum will be atrophied. This is mainly due to alcohol abuse. So I want you to remember those pictures when you think of anterior vermis syndrome. Anterior vermis affected due to alcohol abuse. And what main thing or main structure will be affected? The legs. Remember when we talked about the spinocerebellum here? Wait. Spinocerebellum, we said it's ordered in a specific way, in which the anterior part is more towards the lower limbs. And then as you go back, it will be the upper limbs, the head, and so on. Anterior part is mainly for the lower limbs. So anterior vermis is affected. So the vermis is this middle part, mainly the anterior part. So you'll have, it will affect the gait, it will affect the trunk, but mainly leg ataxia. So most common feature is the leg ataxia. And how can you test that? Other than you can actually see it in the patient, specific test is the shin heel test. So you ask the patient to do this movement, and the patient can't do it properly. It's discoordinated because you have leg ataxia. And the patient cannot walk in a straight line. Everything is ipsilateral. Keep in mind, everything is ipsilateral. Anterior vermis, alcohol abuse, gait, trunk, and leg ataxia mainly. Posterior vermis. Now, posterior vermis, as you go back in the cerebellum, it will affect this part. Tamam? So here you have the vestibulocerebellum, or the floccular nodular lobe. And let's think of the gross appearance of the brain. So we said the cerebellum is behind the midbrain, pons, and medulla. And it forms the roof of the fourth ventricle. Tamam? So any tumor in the fourth ventricle would affect the function of the cerebellum, and it will cause posterior vermis syndrome. So what will it affect? It will affect mainly the floccular nodular lobe due to tumors of the fourth ventricle, especially in children, because they're more common in children. Those two tumors, especially medulloblastoma and ependymoma, this is the appearance on MRI. Those are tumors more common in children, and they're tumors of the ependymoma is a tumor in the fourth ventricle. Again, medulloblastoma in this area will affect the function of the cerebellum, and this will lead to truncal ataxia, and head movement will be affected. So posterior vermis. Posterior vermis, we said vermis means it will affect the trunk and the gait. So you'll have truncal ataxia, and the patient will have wide gait in order to compensate. So the patient, if he stands still, if the patient stands still, he won't be stable. So they will try to spread their legs and have a wide gait in order to be more stable. So this is one typical appearance of a patient with posterior vermis syndrome. And as we said, it's more common in children because of the tumors, and it sometimes involves the floccular nodular lobe because it's down in the posterior side. Truncal ataxia. تمام? We said anterior vermis, mainly leg ataxia, posterior vermis, truncal ataxia, compensating with a wide gait, and hemispheric syndrome. So we said middle will affect the trunk, hemispheres will affect the extremities. So here we have involvement of the cerebellar hemispheres resulting in discoordinating distal movements. It's typically caused by astrocytomas or abscesses. Astrocytomas is another kind of brain tumors. I believe you're taking it in another lecture. Also abscesses, and it's most common in patients with vascular dementia. So if there are infarcts in the cerebellar hemispheres, this would result in hemispheric syndrome. Ipsilateral cerebellar sides. What are the cerebellar sides? We have dysmetria, overshoot, undershoot. We also have dysdiadochokinesia, in which if you ask the patient to do this, they can't do it properly. They'll start mixing up. You have the nose to finger test, and you have the intention tremors. So if you ask the patient will be still, and then if you ask them to point at something or touch something, they'll start shaking. So this tremor is intention tremor. Ipsilateral side. So if the right cerebellar hemisphere is affected, the right hand will be affected. Dysdiadochokinesia, the intention tremor, dysmetria, and so on. Mainly in vascular dementia or infarcts, also with astrocytomas and abscesses. So we're done with the cerebellum. I hope everything was clear. Again, feel free to ask me anytime if you have any other question. And we have 2 questions for the cerebellum, and then we'll move on to the last part of this lecture. Bismillah. A man comes to the ER with a white gait, ataxic, and slurred speech. His history reveals that he has been admitted into rehab for alcohol addiction 3 times in the past 5 years. Arrested for drunk driving twice in the past year. Symptoms are most likely due to atrophy of which of the following? Atrophy related to alcohol is anterior vermis. Anterior vermis syndrome. Patient will have gait and trunk ataxia, but mainly leg ataxia. And yeah. 59-year-old alcoholic presents to the ER with ataxia, confusion, dysdiadochokinesia, and tremor when performing finger-to-nose tests. Which of the following nuclei could be affected? Nucleus fastigious. Okay, let's go back to the nuclei and look at them. We said here we have the dentate more to the hemisphere sides. So lesions in the hemisphere would be more related to the dentate nucleus. And then you have the emboliform and the globus, which are the interposed nuclei. They will be affected in spinocerebellum. So this will affect the posture. Nucleus fastigious is involved in the vestibular cerebellum. So this will affect the balance and the eye movements, which is very common in alcoholics. And we said it will also affect the flocculonodular lobe and so on. So here, the answer is nucleus fastigious because patient has dysdiadochokinesia, tremor when performing the finger-to-nose test, which is the intention tremor and confusion. So yeah, this is it for cerebellum. Now we have the last part, which is the basal ganglia. And yeah, let's get started. Function of the basal ganglia. Now, before going into the anatomy, there's one distinction we need to make. Remember when we talked about the nuclei in the thalamus, we said basal ganglia is involved with motor function, and cerebellum is also involved with motor. Basal ganglia with initiation of the movement, cerebellum with fine-tuning and adjusting the movement. However, if you have a problem with the basal ganglia, this will not cause paralysis. The patient can still move, تمام? But it will cause extrapyramidal symptoms. So you have tremors, you have dyskinesia, you have changes in the muscle tone and the posture, and you have poverty of movement. So those are extrapyramidal symptoms. When can you see those? For example, if a patient has Parkinson's patients can still walk, they can still move. However, they have poverty of movement, they have changes in the posture, they have tremors, and so on. So it is important in the control of normal voluntary movement. However, problem with the basal ganglia war symptoms. Okay, so now we can start with the anatomy. Let's look at our structures first. We said this white thing is the internal capsule, تمام? And then near the posterior limb of the internal capsule, here we have the structures of the basal ganglia. تمام. Okay, let's look at this diagram here. This red thing is the basal ganglia. You see this curved structure? This is the caudate nucleus. So when you look from the side, you can see the whole curved structure. However, if you cut a coronal section, you won't see the whole curve. You'll just see the head of the caudate and the tail of the caudate. So the caudate nucleus is this structure. It's curved if you look from the side. If you take a coronal section, You just see the head and the tail. تمام. And then what else do you have? You have the putamen. This is the putamen, and then the globus pallidus. You have globus pallidus externa and interna. So this is the putamen. This is the globus pallidus externa and globus pallidus interna. You also have the substantia nigra and the subthalamic nucleus. Remember we mentioned the subthalamus when we talked about the structures in the thalamus. We have thalamus, metathalamus, epithalamus, and subthalamus. And we said subthalamus is more important in the basal ganglia. So we'll talk about it here. So we mentioned the main structures, but I want you to remember that the caudate nucleus with the putamen are called the striatum. And this is the main like input to the basal ganglia. Putamen, caudate nucleus together are the striatum. But putamen with the globus pallidus, which is this triangle here, this is the lentiform nucleus. So this is a distinction in the names. You have the putamen with the caudate nucleus and the nucleus accumbens. Those will form the striatum. And here you have the putamen with the globus pallidus will form the lentiform nucleus. تمام? And then we mentioned here the caudate head and tail. Here we mentioned the subthalamus, and just below it is substantia nigra, which has substantia nigra, pars compacta, and pars reticularis. This will be involved with dopamine production. So its main effect in Parkinson's, and it has a role in the pathways of the basal ganglion. So basal ganglia will receive the primary input from the cortex and send the output to the brainstem and the thalamus to the motor cortices. Again, we said the putamen with the globus pallidus will form the lentiform nucleus. And here is the appearance from the sagittal view. Nucleus accumbens is the striatal component of the limbic loop. No, we said the striatum is the putamen with the caudate nucleus and the nucleus accumbens. This is the sagittal view. Here you have the putamen, here you have the caudate nucleus, and in this purple square you have the fibers of the internal capsule. So if there is any hemorrhage in the lentiform nucleus, it will also affect the internal capsule fibers. Again, this is the lentiform nucleus, and here you have the internal capsule. So they are kind of correlated. So any lesions here may affect the internal capsule with the basal ganglia. Again, this is another view. Here you have the head of the caudate, and here you have the tail of the caudate because it's a curved structure. Here you have our thalamus, the internal capsule. You have anterior, genu, and the posterior limb. And here you have the lentiform nucleus, which is the putamen, and the globus pallidus externus and internus. And we said the putamen with the caudate is the striatum, which is the major input. And then the output will be through the substantia nigra, the globus pallidus, and so on. We'll understand them more when we talk about the pathways. Let's talk about the general function or the general neurotransmitters. Main neurotransmitter in the basal ganglia is GABA. GABA is inhibitory. Glutamate is excitatory. So mainly GABA, so the output is inhibitory from the globus pallidus and the substantia nigra pars reticularis to the thalamus. Again, everything is going to be clearer when we talk about the pathways, but for now, just remember that the main neurotransmitter is GABA. You also have dopamine, which is from the substantia nigra pars compacta. Dopamine will also affect the pathways in the basal ganglia, and it's important in like in regulation of the movement. And this will affect Parkinson's patients. And you also have local circuits, which are intrastriatal within the basal ganglia, and this requires acetylcholine. So you have acetylcholine, cholinergic, you have dopamine, dopaminergic, and you have GABA, which is GABAergic. Mainly, general idea is that the cortex will activate the striatum. The striatum will inhibit the globus pallidus interna. Now you can facilitate movement. This is a very, very basic, very general idea of what's happening, but we have different pathways. And the pathways will have different functions and different effects, and the lesions will have different presentations. So we said we have three neurotransmitter systems used in the circuitry of the basal ganglia. You have the nigrostriatal dopaminergic system, from the substantia nigra, striatopallidyl GABAergic system, which is the GABA, between the striatum and the globus pallidus, and intrastriatal, so within the basal ganglia, you have cholinergic system. Basal ganglia has a role in cognition and the mood and non-motor behavior because of the connections with the frontal lobe and limbic areas. So we mentioned nucleus accumbens, which is part of the striatum and the basal ganglia. So basal ganglia kind of has a role with the limbic system and the cognition and the mood. So we'll talk more about the presentations when we talk about the lesions that would happen or the pathologies. Let's talk about the pathways. Now, the pathways may seem confusing in the beginning, but they make so much sense when you understand them bit by bit. So let's take them slowly. You have the direct pathway and you have the indirect pathway. Direct pathway is involved with initiation of voluntary movements. Indirect pathway will prevent the involuntary movements. تمام? Direct pathway to initiate movements, indirect to prevent unwanted movements. First thing is the direct pathway. Let's start here from the cortex. Cortex will stimulate the striatum. So stimulating means glutamate. So we have glutamate being released from the cortex to stimulate the striatum. Striatum is what? The caudate nucleus with the putamen. So now if you stimulate the caudate striatum, it will inhibit the globus pallidus internus segment. Now, before proceeding, let's keep in mind one thing. The thalamus is trying to stimulate the cortex. So what the thalamus is trying to attempt is to stimulate the cortex. And whatever we're doing with the other nuclei before the thalamus, this will affect the thalamus function, and thalamus will either be able to activate the cortex or we won't be able to activate the cortex. تمام? Other thing to keep in mind is that the striatum will inhibit the globus pallidus. Normally, thalamus is stimulating the cortex, and the putamen and the caudate, which are the striatum, will inhibit the globus pallidus. So now let's talk about the direct pathway again. Let's start over. Cortex will stimulate the striatum. Striatum, we said the normal function of the striatum is to inhibit the globus pallidus internus here. So if we inhibit the globus pallidus internus, we will remove the inhibition on the thalamus. So this is disinhibition. Thalamus is trying to stimulate the cortex. تمام? Normally, the globus pallidus is inhibiting the thalamus. If we inhibit the thalamus, we can't activate the cortex, so we can't move. So the direct pathway, no, we're trying to initiate the movement. We said direct pathway wants us to move. So we want the thalamus to work. So we want to remove this inhibition. So we inhibit the globus pallidus internus. So when we inhibit the globus pallidus internus, we're removing the inhibition on the thalamus. So now the thalamus can go ahead and stimulate our cortex. So now we can move. One other thing to keep in mind is that the striatum will activate the substantia nigra. Here, substantia nigra pars compacta will release dopamine. Dopamine in the direct pathway will affect the D1 receptors. D1 receptors will enhance our striatum. We enhance the striatum, we're enhancing the direct pathway, so we're facilitating the movement. تمام? So the cortex is stimulating the striatum. Substantia nigra is also releasing dopamine to D1 receptors, also stimulating the striatum. Striatum now will inhibit the globus pallidus internus. When we inhibit the globus pallidus, we're removing the inhibition. We're removing the inhibition on the thalamus. So now the thalamus can proceed with stimulating the cortex. This is the direct pathway. This is another screenshot again from Words and Beyond. So here we have the cortex, release glutamate to stimulate the striatum. Striatum will inhibit the globus pallidus internus by releasing GABA. Now, globus pallidus internus cannot continue with inhibiting the thalamus. So now the thalamus will stimulate the cortex. Now we can move. Again, we have substantia nigra to release dopamine to D1 receptors and facilitate this pathway. This is the direct pathway to initiate movement. Now to the indirect pathway. Indirect pathway is it's trying to get rid of unwanted movements. So we're trying to inhibit the movement. We said the thalamus, main aim of the thalamus is to stimulate the cortex. We don't want that anymore. We want to inhibit the thalamus. So keep in mind, whatever we're doing in the indirect pathway, we do not want the thalamus to work. Like, Bismillah. A cortex will stimulate the striatum, which means we're releasing glutamate. Plus means glutamate. We are stimulating the striatum. In the direct pathway, we said the striatum will inhibit the globus pallidus internus. Here, let's focus on globus pallidus externus segment. So globus pallidus externus is related to the subthalamus. Things are going to get a bit more confusing now. So it will go and inhibit the external segment. So this is usually inhibiting the subthalamus. So if we inhibit the externus, we won't inhibit the subthalamus. So subthalamus can now function. Normally, subthalamus is subthalamus will try to stimulate the globus pallidus internus. So now, when we remove the inhibition in the subthalamus can function. So subthalamus will go and stimulate globus pallidus internus. Globus pallidus internus, what did we say? Globus pallidus internus wants to inhibit the thalamus. Globus pallidus internus does not want motion. So when we stimulate the subthalamus, we stimulate the globus pallidus internus. So now we're inhibiting the thalamus. We inhibited the thalamus. We said thalamus is trying to facilitate movement. Now it can't do that anymore. So the movement is inhibited. In the indirect pathway, we do not want the unwanted movement. So we're inhibiting the pathway that leads to this area. So GPI will inhibit the thalamus, which inhibits movement. We also have the substantia nigra releasing dopamine, but this time, instead of D1 receptors, we have D2 receptors. So now, if it releases dopamine to D2 receptors, this will inhibit, this will have inhibitory action in the indirect pathway. So we are trying to inhibit the indirect pathway because we want to balance the movement suppression. We don't want it to be too extreme at the same time. So substantia nigra will release dopamine. If it's to D1, it will stimulate this striatum, and it will help with the direct pathway to facilitate movement. Here, in the indirect pathway, to release dopamine, but to D2. D2 will cause inhibitory action. This is another screenshot. Here we have from the cortex, it goes to the striatum. Now, instead of going directly to the internus, we'll go to the externus, inhibiting it by GABA. Externus usually inhibits the subthalamus, but now we inhibited the externus. So now subthalamus can work. Subthalamus works, so it will stimulate the globus pallidus internus. Globus pallidus does not want thalamus to work. GPI does not want thalamus to work. So now we're inhibiting the thalamus, we're inhibiting the cortex. We don't have motion anymore. Clear? I hope everything's clear. Now let's talk about the lesions or the pathologies, and this will help us with knowing what could go wrong in every pathway. Parkinson's, main thing here, our main concern is dopamine. So what will be affected? This area here, substantia nigra. Substantia nigra is the black part here. So if the substantia nigra is involved or diseased, we are affecting the D1 and D2 stimulation. We said D1 usually wants us to move. So if you do not have D1 stimulation, you cannot do the direct pathway and you can't start movement. In very simple terms, if you don't want to imagine the whole pathway, just imagine this. D1 wants us to go through with the direct pathway. You can't stimulate D1 because you don't have dopamine. You can't do direct pathway, so you can't start the movement. You also do not have dopamine going to the D2 receptors. So you cannot inhibit the direct pathway. So the movement will be very hard. We said D2 usually has inhibitory action in the indirect pathway in order to balance. But now if you lose this function, if you lose this action, you will have extra or excess of the indirect pathway. So the movement will be very hard now. So this is the typical presentation of a Parkinson's patient. They will have a masked face, a stooped posture, and a rigid back. And they will be tilted forwards. Now, what's happening with the motion? We'll have shuffling short step gait. So the patient will be walking slowly with the shuffled steps because the movement is very hard. You can't start the movement and you're also not inhibiting the inhibitory pathway. So the movements will be very hard for the patient. They will be shuffling, short step gaits. You have tremors, the hand tremors and the pill rolling tremor. And yeah, this is the movement and the posture in a Parkinson's patient because of um, the lack of dopamine in the substantia nigra. So you can't start the movement and you can't inhibit the indirect pathway. So you can do the voluntary movements, the intended movements, and you can't inhibit the unwanted movements. So you'll have tremors the whole time. تمام. Now Huntington. Huntington, main thing affected here is the striatum. So what's affected? The caudate and the putamen. You have the caudate or the putamen, which form the striatum. If those are affected, we have Huntington. Huntington is a hereditary disorder, and it has like anticipation. So, for example, the if the father has Huntington's, um, it will be inherited in his sons. So for example, the son will have Huntington too, and they will even have an earlier presentation. So they'll be young and they'll be showing signs of Huntington's. What are the signs of Huntington's? You have chorea, you have dystonia, and let's talk about the pathway first, and then we'll talk about the presentation. So what's affected here is the striatum. Now, um, the globus pallidus externus inhibits the subthalamus. This is the external segment. It will inhibit the subthalamus. Why? Because usually the striatum will inhibit this. So if we inhibit the GPE, subthalamus will work to inhibit the GPI. But now the striatum is faulty. It's not working. So the globus pallidus externus will inhibit the subthalamus. So now the subthalamus cannot stimulate the GPI. If you cannot stimulate GPI, GPI usually does not want us to move. You cannot stimulate this, so you cannot stimulate this. So now the thalamus can function normally. The thalamus is functioning, it will send the impulses to the cortex to move. So now you have the thalamus will go crazy. So now it will have excessive movements. So the patients in Huntington's will have chorea, which is dance-like motions, as you can see in the diagram here. They will also have athetosis and dystonia. Dystonia is the contraction here. As you can see, the patient's neck is contracted, which is dystonia. Chorea is the dance-like movements, which is specific for Huntington's. Now, don't confuse chorea with hemiballismus. Hemiballismus is the flinging motion, which is affected in the subthalamus. Huntington's, you have the dance-like motions, which is the chorea. One thing to keep in mind in Huntington's, behavioral problems will appear first before the motor problems. In Parkinson's, patients will have motor issues first, so they'll have the rigidity, the tremors, the shuffling gait, and then they'll have behavioral problems. In Huntington's, however, you'll have the behavioral problems first. So they will have changes in their behavior. The patient's family will notice changes in the behavior, and then they'll notice the dance-like movements, the athetosis, and the dystonia. Huntington, as we said, is an inherited disorder due to repeats in the DNA. You don't need more details now. For now, just know about the striatum and the pathway that's affected, and that behavioral problems occur first, and then the motor problems. And this is the appearance in the brain. So you have the caudate nucleus affected. So this will cause atrophy in the caudate nucleus. So now the ventricles will appear as if they're expanded because of atrophy of the structures around it. Hepiballism is what we discussed in the thalamus. Remember when we said we also have a subthalamus, and for now just remember the dance-like movement, not the dance-like movement, sorry, the flinging motion. This is where it comes. The subthalamus here. We said the subthalamus usually tries to stimulate the GPI to inhibit movement. And the subthalamus does not work. GPI can work. Yeah. If the subthalamus does not work, so now we're not stimulating the GPI. So now the thalamus can work and will cause the flinging motion, which is seen in hemiballism. Sorry for the confusion. I said everything correct was I paused شوي, but I hope I didn't confuse you guys. Subthalamus usually will try to excite or to stimulate the GPI. Subthalamus is not working. we're not stimulating the GPI. So now the thalamus can do its thing. Subthalamus can go on with stimulating the cortex. So now we have the excessive movements, which is the hyperkinetic signs, the flinging motion seen in hemiballism. Again, contralateral basal ganglia, contralateral side. So if it's affected in the left side of the brain, left basal ganglia, flinging motion will be on the contralateral body on the right side. Now, those are different loops in the basal ganglia. You have the motor loop, which will affect the motor function, as we discussed earlier. So everything we discussed was the motor loop. You also have the oculomotor, the dorsolateral the prefrontal loop, and the limbic loop. Now, I just included this slide for the sake of completion. I included also the notes under the slides, just for the sake of completion, but whatever we discussed was the most important things you need to remember. Quick, very quick review of the basal ganglia. We said it will cause extrapyramidal symptoms, not paralysis. The anatomy, we said we have the putamen and the caudate nucleus forming the striatum. We have the subthalamus, substantia nigra. We have the putamen and the globus pallidus externa and interna. Now, everything makes sense after we discuss the pathway, I hope, inshallah. So you can understand what's happening exactly here. Now we said we have the direct and the indirect pathway. Direct pathway, cortex stimulates the striatum. Striatum inhibits GPI, so now the thalamus can work. Thalamus can cause motion. And we have dopamine with D1 receptors. Motion works. So we have initiation of voluntary movements. In direct pathway, we want to prevent involuntary movements or involuntary movements. Here, cortex stimulates the striatum. Now we're focusing on GPE, globus pallidus externa. It will inhibit GPE, which usually inhibits the subthalamus, but now that we inhibited it, subthalamus can work. Subthalamus works to stimulate GPI. GPI usually inhibits the thalamus. We inhibit the thalamus, we stop the unwanted movements. Parkinson's, we do not have dopamine, so you cannot start movements, and the movements will be very hard, and you have the unwanted movements, which are the tremors, the shaking, and the shuffling gait. Huntington, striatum is affected, so now the thalamus can work. Why? Because the subthalamus will not stimulate the GPI, so now there is loss of inhibition for the thalamus, so the thalamus works. In Huntington, which is the inherited disorder, you have dance-like motion, the chorea, you have athetosis and dystonia, behavior problems first, and then motor problems, and finally hemiballismus or hemiballism, which is due to a lesion in the subthalamus. So now the thalamus can work, it will function. In hemiballism, you will have flinging motion in the contralateral side of the body. And this brings us to the end of basal ganglia. Now we just have a few questions and we'll be done, inshallah. I hope everything is clear. I tried my best to simplify the concepts. If there's anything you have a problem with, either refer to the notes, which are taken from your transcription, so it's the doctor's words, or you can ask me. So I hope everything is clear, and let's test our knowledge with the questions. 20-year-old has an inherited progressive neural degeneration of the brain. This resulted in twitching movement of the head, grimacing, movements in the face and lips and tongues, and movements in distal parts of the limbs, and jerking movements. And the neurons in which of the following parts of the brain were degenerated in this case? Remember we said if we have grimacing movements, those unwanted movements, dance-like motions, jerking, this is the first sign that we are dealing with Huntington. Other thing is inherited disease. We said inherited disease is a feature of Huntington. And 20-year-old, remember we said we have anticipation in which, for example, if the father got Huntington's as a 40-year-old, and then the son will have expansion in the trinucleotide repeats. So this expansion will cause the symptoms to start even earlier in the son. So now, even as a 20-year-old, he starts showing signs of Huntington. Huntington is a lesion in the striatum. You do not have striatum in the options. However, we know that the striatum is the caudate nucleus and the putamen. So putamen is the correct answer here. Okay, 20-year-old man has increasing difficulty with voluntary movements because of muscle rigidity. On physical examination, he has difficulty initiating movements. He has expressionless faces. When he is sitting, his hands have a pill rolling tremor. Which pathological finding in the brain is most likely to be present? Difficulty initiating movements, rigidity, mask-like face, pill rolling tremor is Parkinson's. So what finding we'll have? We said Parkinson's. What's affected is dopamine. Dopamine is found in the substantia nigra. So correct answer would be loss of pigmented neurons in substantia nigra. Caudate nucleus is involved in Huntington's. Um, Mammillary bodies. Now we did not discuss anything about the mammillary bodies here, so you can just ignore it. Alzheimer's. These are not features of Alzheimer's. Alzheimer's will have loss of memory, and they will have changes in the motor function, but those will come later on, and it will have a very different presentation than this, not pill rolling tremor and expressionless face and so on. And yeah, hippocampal neurofibrillary tangles, those tangles are found in Alzheimer's too. So now we care about Parkinson's substantia nigra. This brings us to the end of the lecture. Alhamdulillah, I really hope everything is clear. I tried to summarize as much as possible with covering everything that's high yield. Scan the QR code, please, and you can ask me anytime through WhatsApp, email, whatever suits you. And best of luck, inshallah. And yeah, have a great day, everyone.